This is a huge part of what we can help with, okay? Stabilizers, joint stabilizers, and joint stability is a scourge among everyone who is in this world today, because this is a mechanism that we've identified that literally causes the body to develop arthritic degeneration in various joints throughout the body. There's a reason why we have this heavy osseous protection around this area. And this is the nervous system, protected at all costs, okay? From deformation, allowing for movement in the spine, for example, and then, of course, the cranial vault. This is the lines of communication that the body has to maintain at all costs, okay, no matter what. So, my fortunate accident years ago when I was treating a young man who was scheduled for knee surgery for an ACL tear, and then suddenly realizing that I had done something in his pelvis and his joint stability totally restored, and it wound up that his surgery was canceled a few weeks later, was that this connection with various joints that the body will actually turn off in order to prevent strain in other areas. In these areas, we can identify certain muscle groups that we can actually test. We can check joint stability directly, mechanical testing. And but we can also test local muscle tone. For example, in the hip, we have the gluteus medius, we have the paraspinal muscles in the lumbar spine. This is something you can demonstrate to your patients quite easily. They can feel that response in tone quite readily. Whereas you're doing a mechanical test, it might be a little harder. The actual discrimination for those might be harder. And then by neutralizing a primary in a core structure, could be cranium, could be spinal, could be dental, could be even like wrist and hand, foot, ankle, then you can restore stability in these muscles and quickly recheck those, okay? Knee and ankle, so we have the popliteus, the medial hamstrings, the tibialis anterior showing up. And then in the shoulder, we have supraspinatus, and then recently another has come to light, which is the pectoralis minor, which is another shoulder stabilizer, which often can respond. You can detect very easily. We'll go through that as well. Okay. How many people here are testing for joint stability in these muscle issues on a regular basis? That's good. Okay. One of the most common things you'll see is knee issues. You see people with braces on their knees. You see taping on the shoulders, the lumbar supports. There's a reason they're doing that, right? And the reason is because certain movements cause irritation, weight bearing, and climbing up and down stairs. So let's put this leg down for now, Benjamin, like that. Okay. So you can do your standard anterior and posterior drawer test. Okay. So there's a little bit of instability here posteriorly, and you may or may not be able to feel that. Okay. Okay. Then I'm going to test anterior drawer. So I'm going to stabilize the foot. I'll warn them I'm going to put my bum there or foot, whatever, and then I'm going to get in behind the tibial plateau posteriorly. I'm monitoring with my thumbs on the front here. Okay. So I'm only monitoring. I'm not pressing here. I'm going to pull, and that's also coming easily forward in the knee. Okay. So there's instability in both directions here. All right. So let's have a look at, let's just compare this side. I'm just going to come around. It's good to compare so the patient sees the difference, if there is a difference. All right. So we'll check posterior stability here. It's also a little bit unstable posteriorly, so I'd say it's pretty similar on this one, okay? And then anterior, okay, maybe not as bad on this side, okay? A little bit, but not much. Okay, so for posterior stability, what muscle should we check for? Popliteus. Okay, let's put the legs down. Okay, popliteus, we're going to go in behind the popliteal fossa with a flat finger contact, come up into the fossa. Okay, so I'm going to be pushing up. It should feel like a hard Indian rubber ball, and that's got a fairly boggy kind of soft feeling, right, on both sides. Maybe even worse on the left. Yeah. Feel the difference? Yeah, they're not ideal, but we'll see the difference when we find a primary. Bend your knees up. So for anterior instability, what muscle should we check? Medial hamstring, okay. All right, so we want to do about a 45-degree angle right towards the femur from one side, stabilize on one side, come in this way onto the medial hamstring, semimembranosus, semitendinosus. Okay, look for the amount of give there, and it's a little bit on the soft side. It should have a nice firm tone to it. And we compare both sides. I think they were both affected to some extent. Yeah, this one is even worse. Okay. Do you have any difference, any knee issues, for example, one side versus the other? Or?
On the right, I had an arthroscopy surgery.
Okay, but as far as current symptoms, no problems now. Okay. All right. So the thing, yeah, you're going to look at the structure, obviously. The right one is a little bit enlarged. Yeah, definitely more enlargement on the right side. So I would suspect knee issues are going to be structural as well as, you know, issues with stability, okay, local structure as well. Okay, right, so for that situation here, we have a number of primaries that could influence it. This goes all the way down the line. So without belaboring it too much, I'm going to just do a quick check here to see what might be influencing it. Common suspects, you know, thoracolumbar is a big one. Yeah, he's got a large thoracolumbar area showing up. Yeah, a little more left-sided, I would say. And then the other one for anterior instability, typically more pelvic, upper femur. Okay. Yeah, a big response here in the ischium on the left side here. And we'll check for possible sacral involvement as well. That seems to be fairly significant as well. Okay. All right, so let's neutralize a couple of things here. We have big thoracolumbar involvement. Okay. There. You can do these individually. I'm going to do a combined one here with the sacrum and the thoracolumbar. Let's recheck the stability now. Okay. Pejman, can you feel, and I don't know, you may not have perceived much of a difference before. Yeah. Yeah. All right. And then the hamstring tone, right? Can you feel the difference in the tone? And what you can do, yeah, so. Now we'll take this away. Okay, and give it a few seconds. All right, and tell me what you feel now.
I actually feel softer now.
Yeah, much softer, right? And that is a stabilizer, right? So if you neutralize those areas, right, feel the tone, right, strengthens, right? So people should be able to pick that up. I often encourage patients to close their eyes during the testing so they can feel the difference. Yeah, that one feels stronger as well. Okay, posterior stability, right? Feel that. Let's check the popliteus now. Going to come through. Okay. So coming in behind the popliteal fossa, right, should feel like a nice firm Indian rubber ball, right? So feel that tone right there. We'll take these away. And it's good for at least a couple of them to show the difference. Give it a few seconds. Do you feel the change, Pejman? Yeah. What happened? Softens up. Both of them, right?
Yeah.
Yeah, very, very boggy. All right. So very similarly, looking at things like the hip stability. Now your belt is here, so it's harder to tell, but that's okay. Yeah, just quickly move that. Very good. Yeah. I tell my patients when they come in to take off their belt, I say we have similar protocol to in prison, you know, so we have the make sure. Right. Okay. So they're not too bad. The hip stabilizer, but they'll react to similar things, thoracolumbar, spinal, cranial. So you're not necessarily going to know. Look, make sure you check the foot and ankle. Those are other possible issues. For the ankle stability, okay, there's a couple of tests you can do. This one feels a little bit wobbly here. Feel the difference, Pejman? You might not feel that, but the tibialis anterior, feel the tone here. Feel that one, right? And feel the difference.
This is Type more tone
Tone,
here.
more
than
tone,
this, yeah.
exactly. So the loss of tone and the stability correlate, okay? All right, so that one, and then the other one in the shoulder, supraspinatus, we're gonna go right down into the supraspinous fossa. And I'm gonna add the pectoralis minor here. So it's pretty much an inferior pressure down into the supraspinous fossa for the supraspinatus. For pectoralis minor is basically coming from the coracoid process here into the upper little quadrant here, just below the shoulder, and pressure on both sides here to check for pectoralis minor. Looking at supraspinatus on this side, I'd say it's going to be a relative thing, but it's that's a little bit soft, I would say. And sometimes it's uncomfortable as you go out towards the tendon, okay, if it is significant. This one is even more boggy. Do you notice any sensitivity when you get out to the periphery?
No sensitivity, but this one is more sensitive. And I
Yeah,
have
more
it
sensitive,
40% tear in my supraspinatus.
Yeah, so this is what people are often told. 40% tear. I love that. Because many people believe that, right? Okay. You know why it looks like a tear? I'll show you. And they go in and you see the surgical reports and there's no tear. And so the reason for that is because there's no tone there, and they do the scan and they see the fibers under stress. And when it's under stress, you're going to get these the perimuscular fascia is going to go into a state of hyper stress, and the molecular structure is going to line up and look like a white line. Oh, it's a tear, 40% tear. Well, let's see what's really going on. Okay, is it possibly something else? Okay, so we're quickly going to check. Yeah, we see. Yeah, see this whole upper pattern here. Okay, and look at the wrist and hand. Make sure you check that. Yeah, there is something in the wrist on the right side as well. So let's look at the pectoralis minor as well while we're here. Coracoid process. So there is the tone here. Pectoralis minor, it's pretty mushy. Okay, let's compare this one. Okay, and just relax completely. They're both, I would say, a little bit compromised. Now the thing is, are you right-handed? Okay, so if you're right, if your dominant side is going to likely be more symptomatic because you're using it more, then we can look at the structure. Yeah, we do have slight enlargement of the humeral head on that side too. That's going to add to the impingement and stress on the shoulder. So let's say if we just neutralize the upper thoracic here, let's have a look at that. So one of the things you can do is go right onto the supraspinatus before you do that, and then use that as your tester, okay? And then apply the neutralizing effect, let's say, to the upper thoracic, okay? Can you feel the difference? Feel that. Okay, close your eyes for a second. I'm going to add this one. Okay, not as much of an effect. Let's see the pectoralis minor. Okay, remember how it felt before? Remember how mushy it was before? Feel that, and now we'll take this away. Let's give it a few seconds. Can you feel what happens? Start to lose. What do you notice here? Feel that, and feel that.
Less mushy.
Less mushy, right? And let's see if this is more affected by the wrist and hand. Let's see that one. Yeah, it's not much of an effect. So I'm just wondering about another influence. Yeah, I do see something in the upper. Pejman, with your left hand, or Oliver, you can hold that. That's fine. Right about there. Okay, good. All right. Okay, so just feel that now. Take that one away, Oliver. And you can look at the relative influence. You feel the change? Feel
more
that?
mushy, yeah. More
mushy again, yeah. So a dental, typically for upper quadrant, it'll be upper like jaw, maxilla, often on the same side, okay? Okay, so those are the kinds of things we want to look for and demonstrate to our patients. There's so many inputs to the stability issue, okay? The body is going to do anything and everything to prevent more strain coming in, And certain injuries are going to trigger this general response. It's a generalized response, multiple components. That's why I put the scanners on several different areas to influence that. You'll see how significant, if you have more improvement with one of those primaries, it's likely that primary is going to be one of your first targets for treatment. Okay.
So my question is that we're talking about joint instability, right?
Correct.
So I find that my left side that felt more unstable, let's say the calf or
For
whatever,
sure.
for me, it's within the normal range of motion. I have no symptoms. I've never had any injuries, but I have had about 4 ankle sprains in volleyball. I've had issues with the knee, arthroscopic.
That's
I've
obvious.
had
I can see that.
tears,
Yeah.
everything. So all my symptoms, like even, you picked up on the wrist. I have wrist tension in there.
Yeah.
So I'm a little bit confused. Is it because this is fine, it feels more unstable compared to something that is very tight?
Exactly. Yeah, I asked you if you're right-handed, and you said you
Yeah.
are. So you're going to get more symptoms on your dominant side because you're using it more. Okay. You've had more structural injury on the right side, which is obvious. Wrist, arm, okay, knee, right? So all of that will show up. Instability is one factor, but you're not necessarily going to get symptoms from an unstable joint in your non-dominant side. Okay? Depends on what you're doing athletically, right, or other activities. So just a question of time, right? So the fact that you're not symptomatic, what we're trying to demonstrate is looking at the long-term consequences of instability, trying to demonstrate the effect of these things. And the reality is symptoms are like people are aware of this much of what's going on in their body, but the influence, for example, in this area that might be influencing your pericardium, your lung function, spleen, this injury said here is basically just pointing to why some of the symptoms might be showing up. And the same thing, with the, where else was it? In the sacrum, for example, and your low back issues that might be affecting your pelvic floor, could be affecting other things. And then these other symptoms start to appear, okay? So waiting for symptoms and chasing symptoms is a fool's errand, in my opinion. And that's why we want to educate people into what's going on so that we can address many health conditions and help them overcome limiting conditions, overcome pain, but improve overall health. Okay, we want to optimize function. Right. And just remember, there's layers here. There's these local injuries, joint instability. Then we have the cranial influence, the symmetrical, asymmetrical tone. We have the umbilical and meningeal torsion, which adds another layer of complexity. So I wish this was dead simple, easy stuff, but it's not. It's complex because this is a complex system. Joint instability, or the issue is basically your body is actually doing it to protect itself from a more serious injury. But the result is the joints that are unstable are sacrificed. They're allowed to degenerate. They're allowed to break down. That's where you have your symptoms. But our goal is to find the cause of that. And we can demonstrate that restoration of the stabilizing muscle almost immediately. How many people were able to find they were able to turn those stabilizing muscles back on, find the primaries? Good. Okay, so this is really important because you can demonstrate that. You give people an idea that the potential for them is to get better. This is something that we have, no one else is looking at this. You know that? They're saying, oh, sorry, so we're going to wait for you to, oh, there's two things. First of all, they're going to get you on a muscle conditioning program. Okay, that's like saying, okay, there's a lamp over here, and you notice it's not working. And here's a box full of light bulbs. We want you to keep changing the light bulbs, until you're like drop from exhaustion. And they fail to point out that it's not plugged in, right? That's like what you do when you're exercising a muscle that's not turned on. And so you wind up using all the wrong muscles, which means you alter the normal biomechanics of the structure, and you're just adding to wear and tear, right? Stabilizers keep the joint perfectly lined up so that the agonist and antagonist can work on the joint to to perform voluntary motion. These stabilizers are the key to normal joint function. The knee cannot function. If you look at the knee, it's basically just two surfaces floating in the air, more or less. How does it stay in proper balance throughout the entire gait cycle? Well, the only way it can do that is constant moment-to-moment monitoring by the nervous system to perform neuromuscular interaction with these stabilizers to allow for the quads and the hamstrings to perform and the gastroc to perform their function, right? Without that, it's just going to slop around. It's going to cause destruction of the articular cartilage and the meniscus. And lo and behold, we have a wonderful business plan for the surgeon, right? So how can we extend quality of life, help people function better? We can restore stability, restore muscle tone, restore normal framework structure to allow for optimal articular function and performance, and improve the nervous system by correcting, damage to the skull, the spinal column. All of that is possible. But in order to do that, you got to identify the problem, right? You got to assess, look for it. And if you're not looking, I think someone said that, if you're not looking, if you don't realize it's there, you're not going to notice it, right? So it's just, when I tell, chiropractors, I just look at a skeleton, look at the spine, and this guy has a serious class 2 malocclusion. We got to fix that. Hold on. There we go. So what we want to do is look at a really well-built skeleton that's actually cast from a real skeleton. You can show people, most of the good skeletons are from the same model, and you'll see a big depression injury on the left side here, right? And you'll see it enlarged, shoulder girdle on that side, and you'll see things like an enlarged articular process of C1 and 2 on the right, and so on. All these things are noticeable. Same thing with the hip, trochanter enlargement, the acetabular displacement. It's all there, And I tell people their entire history is written in black and blue, right? So that's there. So, you have a really good opportunity to educate people, And what looks like a subluxation may not be, because if the bone is the wrong shape, it'll look like it's rotated, right? And you keep adjusting and adjusting it and wondering why you have to keep doing that. Injuries happen in a myriad of ways, and your scan, your structural assessment, and then ultimately when you get in for treatment, your vectoring will tell you where to position your hands to get the right access to that structure to create the optimal effect, right? And you can test that out before you treat. So by placing the scanner over the area, noticing how it changes or improves other areas in terms of mobility, range of motion, stability, muscle tone, all of those things. And then you treat and you retest, boom. So easy. And the nice thing is you can demonstrate that. Demonstrate that before you treat, demonstrate after you treat. So it's really important to have, that's why the flow chart is so important. And thanks to Oliver for helping develop the flow chart. And you can,
You're welcome.
Yeah.